Hello. Again, my name is Juebin Huang. I'm a faculty and neurologist here in UMMC Neurology Department. And this lecture, we're going to start to talk about Parkinson's disease, or also called idiopathic Parkinson's disease, as the most common, uh, studied and park movement disorder. Parkinson's disease, from the historic perspective, it's a condition that first described by a British doctor, Dr. James Parkinson, in 1817. Dr. Parkinson is not a neurologist and was not a neurologist, but he was a surgeon. He was working in a local hospital in London while he observed some patients being walking around the hospital, across the street of the coffee shop, and so on. He identified the couple of patients he observed. They all have a common features and with the major symptoms of tremor and shuffling gait. And so he called this condition the shaking palsy, and wrote a paper. Many years later, the neurology field identified similar patients, and similar to what Dr. James Parkinson observed. So they started to call this disease Parkinson's disease, especially after the pathology of the disease has been recognized later on. Parkinson's disease pathology, it is a progressive chronic neurodegenerative disorder. And it causes a slow selective loss of dopaminergic neurons in the substantia nigra area, which is located in the middle brain. The clinical features of Parkinson's disease is correlated to the level of loss of striatal dopamine. Think about, you lost the dopaminergic neurons in substantia nigra. The projection from substantia nigra to the striatum in the basic ganglia will produce less and less dopamine, and the degree of dopamine deficiency is correlated with the clinical features of the Parkinson's disease. The gross findings of Parkinson's pathology, typically the hallmark of the disease is the pallor of the substantia nigra. You can see that this is a normal brain, midbrain, card with shows the normal substantia nigra, and this lower part of the panel is the Parkinson's disease brain, and you can see that the area supposed to be substantia nigra is much more pale, and due to the loss of pigmented dopaminergic neurons. Microscopically, Parkinson's disease and can cause loss of the pigmented neurons in the substantia nigra associated with reactive gliosis. About 100 years after Dr. Parkinson identified shaking palsy as a disease, and Dr. Louis, who is a pathologist, identified inside the dopaminergic neurons of Parkinson's disease, there is an inclusion body, which is quite very characteristic for the disease. Later on, people call this type of inclusion body Lewy bodies. People also find Lewy neurites, which is dystrophic neurites that also contain, in the area of degenerative dopaminergic neurons. And later on, people find that there's actually aggregated alpha-synuclein, which is an abnormal accumulated protein, can be found in the Lewy neurites or in Lewy bodies. So this slide shows different level of pathological finding. This is the gross anatomy findings with the decreased pigmentation of substantia nigra due to neuronal loss. And then here shows the Lewy body with the halo. And inside the Lewy bodies, you can see that the core of Lewy bodies, stand for ubiquitin, but the peripheral of the Lewy body stand for alpha-synuclein, which is abnormal accumulated protein. And now we know that it has played a very important role in the pathophysiological of Parkinson's disease. It is believed that when a Parkinson's patient shows symptoms, usually there has already been about 30 to 70% of substantia nigra cell loss. And typically the ventrolateral region of the substantia nigra can show more depletion of the dopaminergic neurons, which is different from age-related neuronal loss. Usually in that condition, it spares the ventrolateral tier. The loss of dopaminergic neurons, again, it's correlated with the striatal dopamine loss to 80 to 90% at autopsy when the patient shows symptoms typically. And we talk about the pathological finding of Parkinson's disease in the substantia nigra. Now we know that based on immunohistochemical staining for alpha-synuclein technology and methodology, we know that we find that there's Lewy bodies and Lewy neurites in many other brain regions outside of the substantia nigra, and also can be found in non-dopaminergic neurons. And typically, this we can see that the pathology can started from medulla and progress to pons, substantia nigra, and then to cortex. And this is just shows the cortical Lewy bodies. And Dr. Brake, a scientist, proposed this hypothesis based on pathologic studies that in Parkinson's disease pathology may start from our fracture bulb and also the dorsal motor nucleus of the vagus nerve, which is located in the lower medulla, and also the glossopharyngeal nerve in the brainstem. And those are the areas that actually can show very early Parkinson's disease pathology. And then when the disease progresses, the pontine tegumentum, including locus coeruleus, myelinocellular nucleus of the reticular formation, and the lower raphe nuclei can be involved. This stage 3 and 4 of Parkinson's disease pathology, you can say that the pathology involving in more so the peduncular pontine nucleus, the cholinergic myelinocellular nuclei of the basal forebrain, and the pars compacta of the substantia nigra. So that typically when the pathology reached to stage 3, the patient started to show motor symptoms because the substantia nigra is involved. And when hypothalamus portion of the thalamus and other part of cortical region, and especially the anterior medial temporal mesocortex involved, it's stage 4. Stage 5 and 6 usually means neocortic association area is involved, followed by association area and the primary cortex. And that's the stage 6, which means the pathology has spread to cortical area, not just the brainstem. Interestingly, Parkinson's disease pathology has also been found by immunohistochemical staining for alpha-synuclein in other part of the central and the peripheral nerve system outside the brain. For example, the spinal cord and then cilia, ganglia, and the gastrointestinal tract, and or the underneath the skin or saliva gland, and it raises the question that where does Parkinson's start? Does it really start inside the brain, or could it be starting outside the brain? That's a question still be very controversial, and then a lot of research has been going on. What causes Parkinson's disease, we still don't know. And so far, and the hypothesis is that interaction between genetic background and environmental factors may work together directly to each other, cause protein aggregation, mitochondrial dysfunction, oxidative stress, and then eventually cause inflammation and excitotoxicity, and eventually cause cell death. And you can see from this slide, there's some common identified genetic, background, including mutation in the alpha-synuclein gene, Parkin gene, and also there's other susceptibility genes may play a role. Environmental-wise, pesticides has been identified as the major risk factors for Parkinson's disease. Those are, evidence that the Parkinson's disease may be caused by the interaction between environmental factors and the genetic background. And touch base a little bit about the epidemiology of Parkinson's disease. How common is Parkinson's disease? And there's a lot of number, but if you can remember this one, and patients in the population 60 years or older, usually there's about 1% of people have Parkinson's disease. Parkinson's disease is much more common in men than women. The mean age of onset is typically around 65 or 60 years old. Most of the Parkinson's disease is called idiopathic. There's about 10% of them could be hereditary. That means they may have a family history of Parkinson's disease or multiple family members affected by Parkinson's disease. This can be those patients caused by a single gene mutation, or those caused by a genetic susceptibility. The life expectancy of Parkinson's disease can vary significantly, and depends on the age of onset and the occurrence of other complications such as dementia. And clinical subgroup of Parkinson's disease can be divided into, for example, tremor dominant and or akinetic, rigid, dominant Parkinson's disease patient. Tremor dominant means those patients have severe resting tremor, but tremor is the predominant symptoms. The akinetic rigid subtype means those patients, they are stiff, slow, but they don't have much tremor. However, the majority of Parkinson's disease patients, they have a mixed feature of tremor and akinesia and rigidity. Again, and Parkinson's disease research study has revealed that there's some environmental factors can be predictive for the Parkinson's disease. For example, cigarette smoking actually interestingly been found to be a good factor for Parkinson's disease. People who have been smoking have a lower chance of developing Parkinson's disease. However, because smoking is a strong risk factors for cancer, for cardiac condition, for stroke, You really cannot tell your patient to smoke to prevent Parkinson's disease, but don't care about other, consequence. Coffee consumption is another factors for protective factors for Parkinson's disease. People who've been drinking coffee have a less likely chance to develop Parkinson's disease. And other Parkinson's disease risk factors, including a family history of Parkinson's disease, pesticide exposure, head injury, and interestingly, constipation has been listed as a Parkinson's risk factors. Well, no, we don't know, and later on we will talk about constipation is also considered a prodromal symptoms of Parkinson's disease. So it's hard to say it's a risk factor or it's part of the disease. The clinical features of Parkinson's disease initially can be very subtle, and first signs can be mistaken for another condition. And a lot of time, the patient may consider, the first signs as normal part of the aging process. They're just a little bit slower, stiff. They think it's just because they are getting old. Some patients may present with persistent mild fatigue, and their handwriting may be a little bit shaky. Or a person might feel unbalanced or have difficulty performing, sit to stand means, getting out of the chair, getting out of car, but mild. Agitation, irritability, depression can be part of the, first symptoms of Parkinson's disease, but it's very non-specific. And the lack of affect, the so-called masked facial phenomena, can be the first presentation of Parkinson's disease. Those symptoms can, present for years until the patient develop much more classic Parkinson's symptoms, and then started to see doctor. Interestingly, one of the other earlier signs of Parkinson's, that maybe, we have patients started to have shoulder pain, started to see orthopedic surgeon for rotator cuff injury. And, when the surgeon observe or examine the patient, they may find there's rigidity in that shoulder or in other part of the body and outside the shoulder. And then, a good surgeon will realize this is probably not a rotator cuff injury. Actually, the patient may have an underlying disease, such as Parkinson's disease. It's not uncommon. We have Parkinson's disease initially present to, orthopedic surgeon's clinic rather than to the neurology clinic. So the key clinical features, the classic 4 cardinal symptoms of Parkinson's disease is the so-called tribe syndrome. And T stands for tremor. Again, it's a rhythmic back and forth motion of the thumb and the hand, usually 3 to 6 hertz. Most evident when the limb is at rest or under stress. And it typically started from one side of the body and then later on spread to the other side. And this is so-called asymmetric presentation. It's a typical phenomenon for Parkinson's disease. R stands for rigidity. We talked about it earlier. And it's an increased muscle tone causing resistance to passive movement of joints, which is velocity independent. That means no matter how fast you move the joint, you will feel the rigidity. This is to differentiate from spasticity, which is another neurologic conditions that can cause increased muscle tone. But in the case of spasticity, the resistance to passive movement of joints typically is velocity dependent. That means if you move slow, and you will not feel the spasticity, but if you try to move the joint faster, you can feel a catch of the joint movement, and typically very characteristic for spasticity. A stands for akinesia, interchangeable to bradykinesia or hypokinesia. It's the difficulty of initiating movement and the slowness of movement. It's the key part of Parkinson's disease. P stands for posture instability, and it's the impairment of balance and the coordination causes Parkinson's patient to lean unnaturally forward. And you can commonly see someone with head down, tilted stance, like in those pictures. So TRIBE is the 4 cardinal symptoms of Parkinson's disease. So you can easily think about, when patient has Parkinson's disease, they are TRIBE, and that's why they have difficult moving. So the TRIBE phenomena are describing the typical motor symptoms of Parkinson's disease. We now know that Parkinson's disease and patients have also a lot of so-called non-motor symptoms. In the earliest stage of the Parkinson's disease disease course, and a patient can have hyposmia, means the lack of smelling function, which may precede diagnosis in 25 to 97% of patients, depends on the study. Fatigue, depression are common non-motor symptoms, sometimes can present before the diagnosis of Parkinson's disease. Rapid eye movement, sleep behavior disorder, those patients have vivid dreams. They act out during the dreams, and like they're fighting or escaping from somebody. This is now considered a very characteristic feature of prodromal Parkinson's disease. Symptoms may precede diagnosis by 15 years or longer. Constipation, as we said earlier, it's prodromal symptoms of Parkinson's disease may precede diagnosis as long as 10 to 15 years as well. In the later stage of the Parkinson's disease, patient can develop a lot of other motor symptoms such as freezing, posture instability, falls, and dysphagia, difficult swallowing. But also they can, start to have a lot of other non-motor symptoms, including psychiatric disturbances, anxiety, or autonomic disturbances such as, orthostatic hypotension, posture lightheadedness, urinary urgency, incontinence, sexual dysfunction. Cognitive impairment is a common symptom of later stage Parkinson's disease, can present mild in the case of mild cognitive impairment, or more severe as dementia. It is believed that more than 80% of Parkinson's disease patients, if they live with the disease for more than 20 years, they're going to develop dementia. That a typical time course of Parkinson's disease can be tracked by, here you can see the 0 means when the patient shows symptoms of bradykinesia, rigidity tremor, and then usually the patient will be diagnosed around the time they show motor symptoms. But before the diagnosis, usually patient may already have presented with other non-motor symptoms, including constipation, REM sleep behavior disorder, hyposmia, depression, excessive daytime sleepiness, for up to 20 years. After the patient received a diagnosis of Parkinson's disease, usually the disease course can last as long as 20 or even more than 20 years. But, with the increased amount of, motor and the non-motor symptoms down the road, and which cause severe disability and then lower quality of life of the patients. The typical diagnostic process of Parkinson's disease is, based on, again, the history and the physical examination. And based on the Movement Disorder Society's clinical diagnostic criteria for Parkinson's disease published in 2015. To diagnose Parkinson's disease, first step is to diagnose Parkinsonism, which requires evidence of bradykinesia with either resting tremor or muscle rigidity or both. And as you can see, that bradykinesia, the slowness, is the most important symptoms of Parkinsonism. And plus a tremor or plus a muscle rigidity, you can diagnose Parkinsonism. After you made a Parkinsonism diagnosis, the next step is to rule out other secondary or atypical Parkinsonism that may attribute to the patient's Parkinsonia symptoms in order to finally make a Parkinson's disease diagnosis. As you can see, that Parkinson's disease diagnosis is diagnosis of exclusion. You have to rule out other conditions that may cause similar features in order to call it idiopathic Parkinson's disease. There are some features that may be much more supportive for Parkinson's disease diagnosis. For example, if a patient presents with a unilateral resting tremor, or if a patient has a clear and dramatic improvement in motor symptoms with the dopaminergic treatment, or if a patient presents with a levodopa-induced dyskinesia, or if a patient has loss of the sense of smell, or with the evidence of cardiac sympathetic degeneration on this nuclear medicine scan, those are evidence that much more supportive for idiopathic Parkinson's disease. There are also other features. If you see it, you can think about those are not typical for Parkinson's disease. For example, at earlier stage, if a patient presents with an unequivocal cerebellum signs, dysmetria, ataxia, or if a patient presents with a downward vertical supranuclear gaze palsy, or if a patient present with Parkinsonism symptoms, but only to the legs without involvement of the arms for more than 3 years. Other conditions including those patients present with cortical sensory loss, aphasia, rapid progressive gait impairment, recurrent falls early in the disease course, early and difficult swallowing, bowel symptoms, and early severe autonomic failure. So all those conditions, if present and make you think about this, is probably less likely Parkinson's disease, especially if they're in the earlier stage of the disease course. Well, we said, Parkinson's disease is a diagnosis of exclusion, but if there is there a way to increase the accuracy of Parkinson's disease diagnosis? And the answer is yes. Oftentimes clinically, we have a tendency we can use levodopa as experimental treatment, and if you suspect somebody with Parkinson's disease, you can go and give the patient a treatment trial. And if you do see a positive response with improvement, that convinces you that this patient may have Parkinson's disease. You can do the olfactory function test clinically, and if you do see that the patient has impairment of olfactory function, that supports a Parkinson's disease diagnosis. Neuroimaging, traditionally we think they come and use the MRI, CT scan, and they would not show any characteristic findings of Parkinson's disease, but they can help you rule out other secondary and atypical Parkinsonism and by specific features on the MRI. There's one imaging modality which is the transcranial Doppler, and it can show hyperechogenicity in the substantial nigra area, which oftentimes much more commonly seen in Parkinson's disease. Unfortunately, this is a technique widely being used in Europe, but not much in the United States, because it's really depends on who's doing the ultrasound. The results may vary significantly. And functional brain imaging, and I'm going to just mention about this DIT scan, which is a nuclear medicine SPECT scan. If it's abnormal, it would support it for Parkinson's disease. The DIT scan is iodine 123 labeled fluopan and SPECT scan, and the ligand is a presynaptic radio ligand selectively target the dopamine transporter, which is here. The function of dopamine transporter is to reuptake the dopamine back to the presynaptic neuron, and in order to reuse the dopamine. And loss of dopamine transporter is indicative of presynaptic dopaminergic deficiency. Think about the Parkinson's disease. Because of the dopaminergic neuron loss, the nerve ends here will be decreased. The density and the amount will be decreased. So the results of that, it will be less dopamine transporter, and that can be detected. If you don't have enough dopamine transporter, the radioligands will not be able to bind to the transporter, and then you will see reduction of uptake of the radioligands in this area of the brain. So in that case, it's an abnormal scan and an indicative of a presynaptic dopaminergic deficit. In that case, Parkinson's disease is one of those conditions can cause presynaptic dopaminergic deficiency. And this is a typical, DIT scan spectrum in an essential tremor patient. You can see the bilateral symmetric, strong, and intensity of the radioligand uptake. And this is a Parkinson's disease. You can see that there is more, the right side of the brain has a more reduced uptake compared to the left side, but both sides is affected, and it's due to the deficiency of dopamine transporter in this area. All right, that's a quick review of Parkinson's disease, the definition, pathology, epidemiology, and the clinical presentation and diagnosis. And the next lecture, we're going to focus on Parkinson's disease treatment. Again, if you have any questions, feel free to email me and the program, and we can get it answered. Thank you.